Hello, class. This is week 5. My name is Dr. Neil Sugi, and I want to start off this class by telling you a little story about little Danny. Little Danny was born on Canada Day in Ottawa. Could you be more Canadian? And he grew up. His father was a civil engineer, his mother was a secretary, and he had a fairly normal life, but he struggled with what was called Asperger's disorder, what is now under the spectrum of autism spectrum disorder. And one of the unique characteristics of little Danny's life was that he was obsessed with ghosts and with law enforcement. And because little Danny had a difficult time relating with others, he often would get upset when others would intrude on his train of thought. And this actually resulted in him being expelled from 2 different schools as a child. Little Danny was somebody that we weren't sure what was going to happen with him. But he took the strengths that he had developed, and eventually he graduated from high school and went on to college. He studied criminology and sociology at Carleton University. And while he was studying, he discovered that he had a talent for wit and for making people laugh with his own unique kind of dry way of communicating that was unique, he felt, to him. And so he started hanging out in nightclubs and working as a comedian. And he enjoyed this so much that he actually dropped out of university. But that wasn't the end of his success. Actually, it was the beginning of his success, because he realized that he had some real talent. Well, little Danny grew into who we now know as the famous actor Dan Aykroyd. Little Danny went on to work for Saturday Night Live, and he turned his obsession with police force into several TV series, including and movie series, including the Blues Brothers. And he turned his obsession with ghosts into, you guessed it, the Ghostbusters. There is an opportunity for success with all children of exceptionality, even little Danny. We have a lot to cover this week, so let's jump right in. We're going to start off exploring a little bit of intellectual disabilities and some of the challenges and opportunities there. But first, it's important to kind of understand the language a little bit. Now, the American Association of Mental Retardation was an international multidisciplinary association of professionals responsible for defining intellectual disabilities. Now, in 2001, they changed their name to reflect the changing role that they have and how they want others to understand what they do. And they changed it from the American Association of Mental Retardation to the American Association on Intellectual and Developmental Disabilities. And this is a trend that has gone on over the last 20 or 30 years, moving towards using more positive labels or trying to avoid labels whenever possible. So, for example, the Canadian Association of Community Living stresses that one should refer to people for who they are not what they are. For example, the disabled. Therefore, terms such as people who have an intellectual disability or people who have a developmental disability would be more appropriate than calling someone mentally retarded. Although mental retardation has been the clinical term for many, many years. A little bit of the basic concepts. Intellectual disability really is a generic term. And it represents a highly diverse group of individuals. Intellectual disabilities include a wide range of functioning levels, from mild disabilities to more severe disabilities. Intellectual disability has most often been characterized by two dimensions. First off, limited intellectual ability, and, secondly, difficulty in coping with the social demands of the environment. The impairment in mental abilities is most often reflected in an intelligence quotient that is significantly below average. This quotient relates to a mental age, the MA, that is appreciably lower than the individual's chronological age, their CA. In addition, these individuals would necessarily demonstrate less mature adaptive skills, such as social behavior or functional academic skills, when compared to their same age peers. Students with mild intellectual disabilities are most likely to be challenged in the school setting. And so that's important to keep in mind. Now, a little bit of the classification of intellectual disabilities. Historically, classification has been done by both etiology, the causes, and the level of severity. So the classification system most often cited in the professional literature is one reported by Grossman, and this would date back to the 1980s. This system uses the terms mild, moderate, and severe, and profound mental retardation. These terms are summative judgments based on both intelligence and adaptive behavior. IQ, unfortunately, has been equated with level of functioning when these terms have been used, so that can cause some confusion. Terms such as educable and trainable have been used in school environments, and the terms are inherently stereotypical and prejudicial and have really been criticized, and because of that, these terms are no longer in use within the education system. An alternative is being to classify intellectual disabilities according to two levels, mild and severe, and to avoid a reliance on IQ scores and considerations of level of severity, considering the level of adaptive skills. So there's been an emergence of an alternative classification based on needed levels of support. And I think this is a much better approach to this. This system classifies individuals based on the needs rather than on the deficits of the individual. So levels include intermittent, limited, extensive, and pervasive supports. Now, when we think in terms of prevalence, it's estimated that approximately 1 million Canadians, so about 3% of the population, have an intellectual disability. And there are hundreds of known cases of intellectual disabilities, and numerous cases for which the cause may be unknown. Intellectual disability is associated with a number of challenges to learning, from attention and memory to language development. Now, individuals' degree of intellectual impairment is really determined by a registered psychologist in the course of a full psychological assessment. So again, a team approach is needed when making a diagnosis here. Now, when we think of in terms of working with children with disabilities, particularly in a school setting and teaching students with intellectual disabilities in an inclusive setting, it's clear that there is a challenge. Educators really must deliver quality programs, or else the prognosis for young adults with intellectual disabilities will not be positive in a general sense. But there's some challenges for general education. For example, there are 4 primary goals for individuals who are mildly intellectually disabled: productive employment, independence and self-sufficiency, life skills competence, and an opportunity to participate successfully within the schools and the community. And these goals really should guide the person working in programs with children with intellectual disabilities. Now, in terms of employment, teachers and workers should build students' career awareness and help them see how academic content relates to applied situations. At the secondary level, this should include training in specific job skills. In terms of independence and self-sufficiency, young adults with intellectual disabilities need to become as responsible as possible for themselves. This means that the successful inclusion of students who are intellectually disabled depends on the ability of teachers and peers and workers in the curriculum to create a climate of empowerment. Empowerment involves self-efficacy, a sense of personal control, self-esteem, and a sense of belonging to a group. One essential element of empowerment is self-determination, allowing the child to practice making their own choices. A focus on teaching life skills is an important consideration to help children with intellectual disabilities achieve competence in everyday activities. This area includes, but really isn't limited to, using community resources, being involved in home and family activities, working on social and interpersonal skills, developing skills in their own care of their health and skills in practicing safe living, using their leisure time and being able to make choices in using their leisure time, and participation in the community overall as a productive citizen. As far as the social skill acquisition goes, this is always going to be a concern, and the child will require some support. Sargent really proposes a model that includes several areas for supporting social skill acquisition with children with intellectual deficits. First one being classroom-related skills development, then school-building-related skills, personal skills, interaction initiative skills, interaction response skills, community-related skills, and work-related skills. So a lot of it focuses on how to initiate a conversation, how to carry on a conversation back and forth, how to conclude a conversation with someone. That becomes a very important part of the whole social skills acquisition process. Now, in terms of inclusion within the education system, the key to including students with, say, for example, mild intellectual disabilities into the general education classroom is providing necessary and appropriate supports. These supports may include personal supports, maybe some natural supports like parents and friends, support services, technical supports. This model really is called the supported education, and it assumes that individuals should be maintained in inclusive classroom settings to the maximum degree possible, and supported in those locations to ensure successful learning. Unfortunately, there tends to be a tendency to simply physically place the student in a classroom and call that inclusion, rather than to achieve the goal of a supported education. So we need to make a distinction there. Supported education means the child is actually engaged in the education process. Okay, so let's now transition to working with children with autism spectrum disorder and with fetal alcohol spectrum disorders. And let's begin with looking at autism spectrum disorders. So the basic concept of autism. Autism spectrum disorders are really pervasive developmental disorders that primarily affect social interactions, language, and behavior. The characteristics displayed by individuals with autism vary significantly. Autism is often referred to as a spectrum disorder, meaning that its symptoms and characteristics can present themselves in a variety of combinations, ranging from mild to quite severe. Autism is a condition that was first described by Leo Kanner less than 50 years ago. Since that time, there's been considerable controversy in this field. Early controversy centered on attempts to relate the cause of autism to poor mother-child bonding, a hypothesis that was later disproved. Many professionals once thought children with autism made a conscious decision to withdraw from the environment because of its hostile nature. During the 1980s, autism was found to be an organic disorder. You can really think, a lot of research has been done here, and you can really think in terms of one of the aspects of autism is a distortion in the sense of touch, where touch would normally be a pleasurable activity, a sensation for most people. The interpretation of touch gets skewed within autism, so oftentimes it really feels like pain. And so if you think in those terms, you can start to have a real sense of how the child is reacting reasonably based upon their internal experience. Historically, autism has been considered a low incidence disability. However, the number of children identified over the past few years has really increased dramatically. Now, recently, Canadian epidemiological research has suggested that the prevalence of autism spectrum disorder has increased from 40 to 60 per 10,000 people, representing approximately 190,000 Canadians. It's also estimated that approximately 1 in 200 children today have an autism spectrum disorder. Now, how do we really define autism? There's many definitions. No single definition that's universal. Two primary definitions are from the DSM, the Diagnostic and Statistical Manual of Mental Disorders, as well as the U.S. Individuals with Disabilities Act, what I've mentioned before many times, the IDEA Act. In the newest version of the Diagnostic and Statistical Manual of Mental Disorders, there are two main changes associated with the diagnostic criteria for autism spectrum disorder. These changes include the diagnosis will be called autism spectrum disorder, and there no longer will be subdiagnosis of autistic disorder or Asperger's syndrome, pervasive developmental disorder not otherwise specified, or disintegrative disorder. And this is a change because for example, in the DSM-4, symptoms were divided into 3 areas: social reciprocity, communicative intent, and restricted and repetitive behaviors. The new diagnostic criteria have been rearranged into 2 areas: social communication interaction and restricted and repetitive behaviors. The diagnosis will be based on symptoms, currently or by past history, in these 2 areas. And just as autism is difficult to define, it's also difficult to identify. Children with autism display many characteristics exhibited by individuals with other disabilities, such as speech and language disorders. Many children with autism are mistakenly classified as multiple disabilities. No stable classification system is used among educators and other professionals, and so that makes it fairly difficult. Early identification is clearly fairly valuable. This concern has really been highlighted with the change in the Diagnostic and Statistical Manual, the 5th edition, indicating that individuals with autism spectrum disorder must show symptoms from early childhood, and even if those symptoms are not recognized until later. So, key characteristics for the earliest detection have been identified in the literature, and they include things like a lack of eye contact, limited social skills, differences in motoric characteristics. Now, there's lots of theories about the causes of autism, but there is no single specific cause of autism as far as we can understand. Organic factors such as brain damage, genetic links, and complications during pregnancy may cause this condition, but in most cases, the cause cannot be confirmed. In general, autism occurs across all segments of society, and most accepted models suggest a combination of a genetic base influenced by environmental factors, such as toxins, what we call teratogens. Now, characteristics of an individual with autism, while they vary, children with autism have generally a great difficulty relating to other people. They avoid eye contact and have significant impairments in communication. They're typically described as being understood by 2 major groups: the behavioral deficit, so an inability to relate to others, and the behavioral excesses like self-stimulation. Although most of these characteristics are negative, some children with autism present some positive as well as unexpected characteristics. And then there's self-esteem and self-concept problems are common in individuals with Asperger's syndrome. Now, Asperger is used to be kind of separate from autism because it was where a person had trouble with socialization but still had interest in socialization. In some cases, children with autism display unique splinter skills. These types of skills are found in only a small number of children with autism, however. So the typical Rain Man scenario is not typical for children with autism. Formerly, the prognosis for children with autism was fairly pessimistic. Most children with autism would grow into adulthood with severe impairments. However, intensive intervention programs have been somewhat effective with working with children with autism, although it's fairly well recognized that no single method is effective with all children with autism. It really is something that needs to be narrowly specialized to the needs of the child. There has been some recent research that indicates that behavioral treatment of children with autism, especially young children, may result some significant long-term gains in intellectual and adaptive behavior areas. And it's also recognized that social skills training is really essential for children with autism. Although, again, no single curriculum seems to be appropriate for children with autism. There's too much variability to say that there's a one-size-fits-all approach. Programs for students with autism really should be age-appropriate and developmentally appropriate. But they have recognized that there is some benefit for certain drug therapies that may be prescribed for certain children with autism. So that's another thing that the team working with the child with autism should be considering within this. Okay, let's go on and explore a little bit of fetal alcohol spectrum disorder. Now, fetal alcohol spectrum disorder really relates to the disruption of a teratogen, in this case alcohol, in the brain development of the fetus. And that has some long-term developmental challenges for the child. We can speak in terms of maternal consumption of alcohol during pregnancy can cause damage to the woman's unborn child, and a range of disabilities will result. The term fetal alcohol spectrum disorder really is an umbrella term that refers to this range of disabilities. And these are really lifelong conditions that affect the individual, the family, and the community. The disorders that may be included under the umbrella of FASD include fetal alcohol syndrome, partial fetal alcohol syndrome, alcohol-related birth defects, and alcohol-related neurodevelopmental disorder. These are part of the whole area that we're going to be dealing with here. And just remember that just like a lot of these, the diagnosis of these disorders should be made by a medical doctor. And it's important to bring in the whole team to better understand what's going on there. And it's important to note that individuals with FASD demonstrate diverse physical, health, academic, and learning characteristics. Unfortunately, we don't have a good handle on, there's estimates, but we don't have a good epidemiological handle on FASD, really. When we strive to understand FASD, again, in Canada, the definitions vary widely, particularly within education systems. But overall, FASD is diagnosed by the medical practitioner when there is known significant prenatal exposure to alcohol, and the child exhibits evidence of growth retardation, central nervous system damage, as well as some fairly unique facial abnormalities. Partial fetal alcohol syndrome is diagnosed when maternal alcohol exposure can be confirmed and an individual demonstrates learning and behavioral difficulties and some, but not all, of the physical signs of FAS. Okay. Now, individuals who may have been affected by prenatal exposure to alcohol are really identified by individuals working in a variety of settings. So this can come to the attention of a caregiver, of a community health nurse, of an educator, and then they are referred for a diagnosis. And a team of professionals will typically be involved in the assessment process in order to get a clear picture of what is going on with the child. So this would include, among others, an educator, obviously your medical doctor, a psychologist, a speech-language pathologist, and so on. Now, we have a fairly good understanding of the causes of FASD. There are some critical points within fetal development that can be very easily disrupted by a teratogen, some kind of poison or toxic chemical that can disrupt those key points of development. And unfortunately, alcohol is one of those teratogens, and it can do profound damage. So the effects of prenatal exposure to alcohol on an unborn child are influenced clearly by the pattern of alcohol exposure, the threshold of the amounts of alcohol in the blood, the timing. Timing really is key for the exposure during the pregnancy, as well as obvious other factors like nutrition, maternal health of the mother, and so on. Now, people with and children with FASD suffer these disabilities from birth, and it's a result of the brain damage caused by the alcohol. So they will typically have visual and hearing impairments, memory difficulties, impulse control, and then there are some secondary disabilities that develop over time. And often these can be a mismatch between the person and their environment. So there can be some mental health problems, some frustration, some employment difficulties. And with the variability among individuals diagnosed with FASD, the unique strengths and areas of need of the individual will need to be taken into consideration when planning and implementing interventions. Just like a lot of the disorders that we've talked about this week, understanding the individual needs is essential in order to be able to provide an educational structure to work with the child. So all of that is clearly very, very important in this process. And we'll stop there for this week.